Hi, I'm Dr. Lori Pierce, President of the American Society of Clinical Oncology. Thank you for tuning in to this discussion on social determinants of health and their impact on cancer care. The purpose of this podcast is to educate and inform. It is not a substitute for medical care, and it is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experiences, and conclusions. These discussions should not be construed as an ASCO position or endorsement. For this series on social determinants of health, we invite guests with a wide range of views and perspectives. Some of these conversations may be provocative and some even uncomfortable, but ASCO is committed to advancing equitable cancer care for all individuals. Every patient, every day, everywhere. I have dedicated this vision to my term as ASCO president. These conversations bring many voices to the table, voices that we need to hear in order to move forward and find solutions. We hope you learn new ways of thinking about these issues, and we invite you to join us in working toward a world in which every person with cancer, no matter where they live or what they look like, receives high-quality, equitable cancer care. Thank you.
Welcome to the fourth episode of the ASCO Social Determinants of Health series. I'm Dr. Hala Borno. I'm an assistant professor of medicine at the University of California, San Francisco, and a genitourinary medical oncologist. I have the pleasure today of being joined by Dr. Fumiko Chino, who is a radiation oncologist from Memorial Sloan Kettering. This series is part of a new initiative proposed by ASCO President Dr. Lori Pierce, focused on increasing oncologists' understanding of social determinants of health, its impact on patients, and modifiable risk factors for cancer. Inspired by Dr. Pierce's presidential theme of equity, every day, every patient, everywhere. In this episode, we will look at issues of financial toxicity and related barriers to cancer care. Again, thank you, Dr. Chino, for joining us today. First, I thought I would ask, what do you consider to be financial toxicity, and how can it be a barrier to access to care?
Thank you so much for having me. I am very passionate about this topic. I have dedicated my life to it, and it's actually the reason why I am in medicine. I think financial toxicity is it's a hot topic nowadays, especially with the rising costs of cancer care, and then I think highlighted by the COVID pandemic. But financial toxicity is really a patient-facing problem, meaning it's how patients deal with the costs of their cancer care and how that affects the quality of their care, their access to care, and ultimately can affect their survivorship from cancer. Personally, interested in it because of my own experiences with financial toxicity, and it's really the reason why I ended up in medical school at all. I think, realistically, it's like the whole adage where unless you ask about a problem, you're not going to identify it. And from my own experiences, I know that there are patients that you will see in your clinic that are having problems with financial toxicity, but they won't necessarily talk to you about it until they're given permission. And so I think this topic is increasingly important, and it's something that I'm really happy that we're spending some time with today.
Dr. Chino, thank you again. You really have been quite open about your personal experience, a very powerful experience to highlight this critical problem. Do you mind sharing a little bit about that story and sort of how does that impact the way that you interact with patients in your own practice and also inform your research?
I think that my story, my husband's story, and ultimately kind of our struggle through the healthcare system really highlights a lot of what this, whole issue is about the social determinants of health. And I think the lens I bring to it is someone who's been on kind of both sides of the stethoscope, so to speak. So, my husband was diagnosed with cancer at a very young age. He was in his 20s, and unfortunately, we dealt with some very poor quality health insurance, which did not have a lot of coverage for cancer. And we had a lot of out-of-pocket expenses for our care. Ultimately, I had to quit my job to help take care of my husband. And when he died from cancer, when he was less than 30, it left me with an incredible burden of debt related to his cancer treatment. I think the flip side of the access problems in terms of insurance is that I have a very privileged background. Unlike a lot of patients with cancer and families of cancer, I am from a pretty wealthy family. So I was able to rely on the support of my family to help me get me back on my feet. And even again, when we were suffering these great costs, we had people who could loan us money. And I think that privilege that we had really helped us stay at least minimally afloat with our struggles with financial toxicity instead of, completely going under. And I think that really kind of highlights some of the disparities that for patients that don't have, wealth in their family or people that they can rely on to loan them money or flexibility within their jobs, financial toxicity of cancer treatment really hits them so much harder.
Yeah, I mean that's certainly a really powerful experience, and I do in a moment want to hear how that informs the research questions you asked. But I do want to first highlight that you brought up two really important points. So the first point is this notion of coverage, where access to insurance doesn't necessarily mean access to affordable insurance, and that this issue of cost sharing and out-of-pocket costs that patients bear can be, quite burdensome and compromise their circumstance. And I think your story certainly highlights that. The other piece that your story highlights is this notion of wealth versus household income and how different individuals enter their cancer journey from a different circumstance. And that circumstance of wealth versus household income can have huge ramifications on their experience of financial toxicity. So I think that that's a really critical point to make. Could you share a little bit about how that experience now has become really the cornerstone of the research questions you're asking in your academic career? And then have you sort of carved out certain solutions to identifying these among patients that you're seeing?
I think that the experience that we had in terms of navigating the healthcare system and the obstacles and the sort of the rat race that cancer care treatment is for everyone, especially again, coming from our background of having, a high educational and a family in medicine, and just how difficult it was for us really highlights for some patients how it can be insurmountable. And these problems of access or even getting the right diagnosis. So my husband was given, I think, 3 false diagnoses before he was actually told he had cancer. And then from cancer, he was originally told he had non-Hodgkin's lymphoma. And he ultimately ended up having a high-grade neuroendocrine carcinoma. So realistically, those barriers to even getting the right diagnosis are even worse for patients that may have a lower education standard or may have built-in racism within the system, which is holding them back from being able to trust their healthcare team and being able to, get the proper diagnosis and the proper treatment for their care. I think our experience has really focused me on trying to think about highlighting the populations that really could benefit the most from an intervention, and then piloting specific interventions that may actually help people receive the high quality, high value cancer care that everyone really deserves. I mean, I think, within the United States, we like to think of ourselves as being leaders. And I think that to call ourselves leaders, we need to lead. We cannot live in a society where, a third of our patients are really suffering huge burdens related to the cost of their cancer care. And highlighting a little bit about what you had said before about wealth, I mean, we already know that, for example, Black families have 1/10 of the wealth that white families have in the United States. There was a really compelling Brookings evaluation of that. So if you think about just the out-of-pocket burden for cancer care eroding wealth, what we're talking about with financial toxicity is something that can really be durable within families. So not just eroding the financial security of a patient, but also potentially compromising the educational, success of their children, or, causing housing instability within the family that affects the entire family unit. So, thinking about these issues are really what has galvanized me to consider what are the next steps to actually getting people the care that they need in a facilitated way. And I think, again, not to bring up COVID again, but that's really highlighted the gaps in the US healthcare system and the patients that are disproportionately affected by burden. So if you think about someone who has now potentially lost health insurance or does not have the job flexibility or paid sick leave to deal with a cancer diagnosis, we're talking about an entire group of patients that are now going to have even worse cancer outcomes. And we know that, for example, patients that are, the working poor actually, those with essentially borderline private insurance, that they really do suffer the most in terms of financial toxicity, in terms of their out-of-pocket costs and their coverage gaps in terms of what their insurance insufficiently covers in terms of their cancer treatment are the highest. And that's really, in terms of, the people to really think about, how do we help them? How do we get them the care that they need? That's really what I'm most interested in pursuing.
Really important points that you brought up. I think we can't ignore our context, the COVID context. And certainly this current pandemic has shown the spotlight on the relationship between disease and, our financial circumstance, and in a variety of ways. And so I think it sort of emboldens us to understand and to evoke change in our clinics, in our health systems, in our communities, to have conversations around financial toxicity and the relationship between financial toxicity and cancer care. And also emboldens us to start operationalizing, assessing patients for financial toxicity. So, when I've had conversations with my colleagues and done my own research in this space, I've observed that clinicians often feel ill-equipped to manage issues and problems around financial toxicity that they may identify in clinic. And of course, when you feel ill-equipped to navigate a problem that you identify, it may, of course, make you reticent to even identify it. And so what are some potential solutions that, our colleagues who might be listening to this may be able to take with them in their clinics and practice in order to start unpacking and addressing this problem?
No, I think that's a really good question, because I think that's the most common concern that I have from providers when I talk to them about financial toxicity. And I'm so pumped in terms of, like, we need to address it. We need to be asking patients. And it's funny, we did a survey of our patients. This was actually before COVID, to ask about some things that would actually, help their financial situation related to their cancer care. And some of the solutions were honestly very, very basic. Minimizing wait times so that people could actually get back to work and not have to take a whole day off of work. Having a food or a snack in clinic so that people would, be able to actually, get some food in them so that they could maybe go back to work. And I think, MSK has really highlighted the idea of having a food bank embedded in certain clinics to try to help with food insecurity. Providing things like parking vouchers or, bus passes or metro tickets to patients to try to help with transportation. I mean, really basic, fundamental, like, access problems. And I think that, the larger issues outside of just the mechanical issues is that to realize that, we are part of a multidisciplinary team. I would never treat someone, I'm a radiation oncologist. I would never just, start zapping someone without, talking to the medical oncologist and potentially also the surgeon to really think about, well, how do we coalesce a good treatment plan for someone? And I think you can really think of financial toxicity in a similar way, which is, we need to bring in all of our potential assets. We really need to think of our assistants within social work or the social work team or patient financial services to really rally all of the available resources for our patients. And I think, the thing I always say is that, we can lower costs for patients. We can't necessarily lower them to zero, and we can't lower them for every single person, but we can really make a meaningful difference. And it's a matter of getting people the help that they need, or sometimes just, that little bit of, I'm going to miss my rent this month, a little bit of philanthropic funds that can actually tide them over so that they don't fall into a larger hole related to their cancer diagnosis. The study that I quote most commonly is actually one by Reshma Jangzi from the Michigan group, which found that 1 in 20 Black or Latinx women who were treated for an early stage breast cancer actually became housing unstable related to their treatment. So they had an early stage breast cancer, totally curable, totally treatable, and yet ultimately ended up homeless related to the cost of their treatment. And you cannot help but think that some of that would be preventable if we could just provide people with some acute assistance when they're in need. And again, rally all of the resources around them. And it's not just social work and patient financial services. There's national initiatives to try to think about, well, how do I lodge patients during their cancer treatment from, for example, the Hope Lodges? how do I, get them to their treatment so that they're not paying for taxis, or they're not trying, they don't have a car, so that, how do they get to their radiation treatments? Or how do I, rally philanthropic funds to think, well, what about that extra $300? I just really need to pay my light bill. And there are, resources, they're not, again, infinity resources, but they can actually help our patients, and we just need to facilitate them getting them.
I think that's an incredible point. I think, what I'm hearing from you is, why don't we look within our own clinical environment, the way that we deliver care, and identify areas that generate burden and areas that could be streamlined? Because while there are some opportunities to address indirect costs associated with care, such as travel, lodging, and there's a lot of innovation in that realm, this notion of economic opportunity loss, the loss of wage as you receive care is difficult to measure, not measured operationally, and can be quite burdensome. So if we streamline that healthcare delivery experience, perhaps we can start, addressing the costs that we're making our patients bear in order to receive care. So I think that's a really important point. And it brings me to, a question is, we all acknowledge, in the era of COVID-19, there's been a rise in utilization telemedicine, which may be addressing, a lot of these different issues around receipt of care, parking, travel time, waiting in the waiting room. Do you tell me a little bit about how you've thought about that approach? And do you think that it's, a solution that we should be carrying forward in order to address this notion of financial toxicity?
I think that we are all forced to rapidly implement telemedicine because of COVID-19, and I think one of the few benefits of COVID was that it forced us to really think about what are the barriers to telemedicine, what are the potential ways to deliver high quality, high value cancer care from a distance, and what are the real true assets and potential risks of that. And, we actually, within our own group, just recently published something in GNCCN. And specifically, my question about the rollout of telemedicine was, how much was it actually saving patients? And, the majority of patients did say, what, telemedicine helped. It helped reduce my treatment costs. I think the flip side of that is that we know that, based on some research that's already been presented, at least in abstract form, that telemedicine has not been rolled out evenly. And so there are potential racial ethnic disparities and socioeconomic disparities in terms of the capacity for someone to get a telehealth appointment, to feel that is like a trusted conversation, and to have, just the technical capacity, video phone, Wi-Fi, to actually, get telehealth in. So I think that telehealth does present some really good opportunities to improve value within cancer care and to increase affordability. But the pitfalls, I think, are also true, which is that we can't just say, oh, well, this is great, everyone I know has an iPhone, so I'll just, FaceTime all of my patients, and neglect the patients that are really, struggling. They don't have Wi-Fi. They're not able to have a fast connection. They're not able to hear you. And they would really benefit from an in-person visit, because communication may be a difficulty, or trust may be a difficulty. And those are patients that, again, we need to tailor our interventions and make sure that we're using the right tool for the right patient. The implementation of telemedicine is like precision medicine, right? We need to actually deliver the best care for the person who's in front of us. And it's not one size fits all.
I absolutely agree. I mean, I think, the social determinants of health integrated with precision medicine, how do you individualize your intervention is key. And if you do use this one size fits all approach, you will likely widen the treatment gap in whom we are serving. So I absolutely agree with that. And I think your points are well taken. I think, for our listeners, I really want there to be sort of a tool that they can use in their own clinic as they interact with patients. How do you approach this with patients in your conversation? What is, a takeaway that they can have that they can carry with them in their clinical practice?
I think that, drawing from my own experience and realizing that we were suffering greatly from our cost and yet afraid to speak about them to our provider, just realizing that sometimes patients just need the okay. So they need you to ask them, are you having problems related to the cost of their care? And then, you do need to have some small investment, at least in terms of knowing what the resources are available. And that could be a simple conversation with your patient financial services group or your social work team, and know what resources are available within your own institution. I think shockingly, we've found that, we have great resources here at MSK, and we also have patients who are really suffering. And yet there's this disconnect where patients are not being appropriately referred to the resources that we have. And, they're suffering in silence. Patients aren't bringing up the topic, providers aren't bringing up the topic. And so there's this missed opportunity to actually provide the best quality of care tailored to that patient. So, just asking the question and then knowing what potential resources are available, even something as simple as like a parking pass, like, hey, do we have parking passes that we can give patients? You'd be surprised how much that, just a small piece of paper, it's $20, can really make a difference to some of our patients. Or even asking, how do we coordinate your care so that you can have a minimal amount of time off of work? How do we facilitate you actually, maintaining your health insurance through your job so that you're not worried about not just the lack of health insurance for you, but also for your young kids? How do we maintain your job related to your, I again treat with radiation, so it's a daily treatment, typically for a period of weeks. How do we treat you at the right time of day so that you actually don't have to take more time off of work, so that you actually have income coming in to offset the debts, and the bills that are then, because if you just have debts and no income, it digs you deeper into a hole. So I think all of these things are part of, again, this idea of precision medicine, which is not necessarily next generation sequencing, but like actually generating the right plan for the person in front of you. And I think the first question is always just asking.
Absolutely. Precision medicine isn't just about genomics and targeted therapeutics. It's also about identifying the unique challenges a patient experiences. And I think you've given me a lot of lessons about what I can carry in my own clinical practice. And hopefully that can also have a ripple effect on other listeners today. Thank you for joining us for this episode of the ASCO Social Determinants of Health series. To keep up with the latest episodes, please click subscribe. Let us know what you think about the series by leaving a review or by emailing us at professionaldevelopment@asco.org.
Thank you for listening to this week's episode of the ASCO eLearning Weekly Podcast. To make us part of your weekly routine, click subscribe. Let us know what you think by leaving a review. For more information, visit the Comprehensive eLearning Center at elearning.asco.org.